The reason why I got interested in standalone fusion is quite simple. In the United States, outpatient surgery is on the rise. Simplifying everything is key to that. And eliminating pedicle screws is a big part of the solution to make these surgeries more suitable for an ASC, where there's lower cost, lower reimbursement, along with lower complication and readmission rates and so forth. So all of those kinds of things are obvious. Having good prognosticators, we wrote that up in several articles regarding the use of the MRI scan here in clinical neurology and neurosurgery, as well as the value of a positive predictive value of a diagnostic injection, very important part of the protocol to identify the painful level. And the reliability of that is fairly high, and I'll talk about that in my lecture later today. The readmission rates are low, very low in fact, less than 1%. Complication rate also 1 magnitude lower in terms of dural tears and epidural bleeds and so forth. It can also be quite useful after previous surgery, so it's an excellent, elegant tool to deal with more complex problems. These articles talk about long-term follow-up here in conjunction with the patient series from Dr. Young with favorable outcomes, 5 years with the inside-out versus outside-in, my preferred technique. This is an editorial where we compared the two together. Why interbody fusion? Well, they make the fusion more reliable. Cages can contain the bone graft and restore neuroforaminal height. Disadvantages are related to subsidence, migration, and the need for posterior supplemental fixation. So having a graft where that is not necessary, or an interbody fusion cage where that's not necessary, is obviously of advantage. Some non-expandable solutions are out there that are second and third generation, but they all rely on end plate sparing decortication. They need to be impacted over a guide wire to be deliverable with an MIS technique. And here's an example of an OLIF cage that's a PEEK device, and that requires supplemental fixation, which I said is disadvantage in my world. We played around with a non-expandable PEEK cage with no bone graft chamber, and this was done in patient with end-stage vacuum disc disease that was painful, and there's a case report of 2 cases here in collaboration with a team in Colombia. And it turns out with these 2 clinical examples here that actually did work out quite well. But there obviously are some limitations to that. A post-op CT scan did show that PEEK cage did not dislodge at all 6 months post-op. That's all anecdotal information. Now, the expandable technology, obviously there are cages that both vertically and horizontally expand, but they have no bone graft chamber, and that bulky design is not really conducive for an endoscopic percutaneous implantation. So I use a different device. It was intended basically for a PLIF approach, and you can place it obliquely, or you can use 2 implants that also exists for cervical. And you can see that we talked about that earlier. I think Dr. Morgenstern mentioned the ability to have a bone graft chamber that you can fill with graft. So that device has that ability and an expansion mechanism that, as I will point out later, leads to stress concentration right at the end of the cap. Here are the steps. And I wrote this up in a technical note article in the Journal of Spine. And that's where these images are from. Indication are the regular ones regarding instability and spinal stenosis. Access is a transforaminal approach. In fact, it's a variation of the transforaminal approach through the facet joint. Dr. Dowling and I wrote this up as a transfacet decompression. I think Alvaro is going to show some images regarding that in more detail. But in panel D, you can see the axing nerve root. So having resected most of the facet joint here actually creates quite good access to the inner space. Here's an example of expansion, delivery of bone graft, and final position. In C, you can, in panel C, you can see I'm checking the nerve roots, whether that lateral recess is free. Here's a video thread of the operation. Patient is in a prone position. I like having the C-arm opposite from me. Access planning is standard. I find that a 45-degree attack angle works best for placing the cage and works best for the facetectomy. If you come in too shallow, then resecting the supraarticular process can be difficult. If you come in too steep, then it forces your cage position to be more lateral. Here's some intraoperative video. You can see I have the working cannula inside the disc. Here's a transfacet resection. I'm going straight through the joint space. Ligamentum flavum resection. And now under direct visualization, endoscopically visualized during the end plate preparation. I like to use a sheeted drill, then trials. The disadvantages obviously is that the axing nerve root is right in the line of fire, and there are some postoperative complications or problems with dysesthesia. The cage then goes in over a thick nitinol guide wire, and here you see how I'm placing it. At L5S1 it can be difficult. You have to maneuver around the ilium, the sacroiliac, and sometimes the transverse process, and in cases of transitional anatomy it can also be quite difficult where it's not a straight line of fire. Bone graft is being applied through the central working channel, and then an end cap is positioned after the expansion to contain the bone graft. And that's how that looks at the end of the case. So I did write this up. We have much more cases as now. We're shy of 150 cases, with some of them having 8-year follow-up. But I wrote this up, I think, in the Journal of Spine as well. Here's the level distribution. Actually, it was neurospine. And here's some case examples. Spondylolisthesis, 80-year-old female, stenosis. I did a previous transforaminal decompression on her and didn't result in long-term relief, a lot of back pain, and then I did this same side axis transforaminal fusion surgery that resolved all of her problem to the extent that she was happy enough to give us a TV testimonial. Another example, spondylolisthesis with transitional anatomy. Grade 2 here, and you can see the attack angles can be quite steep, but as long as it lines up on the lateral plane, on the lateral view, that's usually not a big problem. The configuration of the ilium is a much bigger constraint than the axial alignment or vertical collapse due to degeneration. There's some postoperative images, 6 months. An adjacent segment, here's a patient where I did an L4-5 LEW-LIF sometime earlier, and then did the L5S1 I think a year later. I like staging those because if you have stress concentration on one vertebral body on the superior and inferior end plate, you can see vertebral fractures, and I'll show an example of that in a minute here. Here's a follow-up on these 48 patients, gender distribution. Left side, for some reason, is more symptomatic. Age distribution, normal. And regarding results, you can see mostly 87.5% excellent and good by McNabb criteria. This tells the whole story here. If you look at the green shaded area, that's the first 5 weeks or so where patients are complaining of dorsal root ganglion dysesthesia pain. That's very common. So I tell every patient about that. You can see 29 patients had that. That's a fairly large number. They all resolved with supportive care, but you need to talk to your patients about that. Then the pink shaded area is the period of time where additional interventions were needed, additional surgeries or something to revise. And so once you get past the 5 months period, usually patients are out of the woods. So,
Professor, time?
Almost done.
Yeah.
30 seconds.
Sure.
Thank you. All right, problems. Here's a cage extrusion. I moved that one with endoscope. Here's a fracture. The patient actually had metastatic disease, so that was then revised. And here's a cage fracture that was asymptomatic, so I didn't do anything with it. Repeat surgeries were done for mostly adjacent segment disease, hardly any reoperations on the same level or same site. Risk factors were osteoporosis and multi-level stenosis. We measured the subsidence and found that there's always some rotation and vertical subsidence of these cases, and poor results were associated with a subsidence into the superior end plate, not the inferior end plate, the superior end plate of the vertebral body below. Thank you very much.